Well, hello, everybody. Good afternoon. My name is Garrett Schmidt. I am the managing editor for VBC Exhibit Hall. And I'd like to welcome all of you today to our live webinar that's hosted by CarePort, which is powered by WellSky. And it is titled Transforming Transitions for High-Risk Patients. And this is a really popular title. We've got a bunch of people here today. So we're really excited to hear from our speakers, which I'll introduce in just a moment. A couple items of note before we get started. This is a traditional webinar format, so you don't need to worry about muting your microphone or turning off your camera. We can't see you or hear you, but we do want to hear from you. So we are going to have a Q&A session towards the end that we're going to take as many audience questions as we have time for. So if you have a question at any time, you can use your attendee module. There is actually a place for questions. It's different than the chat, but there's a place for questions there. And go ahead and submit your question there. Again, you don't have to wait until the Q&A to do that. And we will get to you if we can. If we don't have time, then someone will get to you via email afterwards. So please ask your question. And then finally, the session today is being recorded. So everyone who has registered, whether they were able to attend today or not, or if you for some reason had to leave early, I'm going to send a link to the recording after the fact. So maybe a couple hours or sooner after we're done, you should get an email, and there'll be a link to the recording as well as to where you can download the slides and interact with the team there. So finally, without further ado, I would like to introduce our speakers today. We have Mr. Tommy Gautreaux, and he has over 20 years of healthcare experience. His background includes 11 years of critical care, emergency department, and disease management experience, followed by a transition into non-clinical role with National Hospital Medicine Organization, where he worked focusing on performance management. He's had various roles overseeing performance management for hospital medicine practices and performance management nurses across the Northeast. He is now with CarePort and is instrumental in transforming care transitions for his clients at practices around the country. So welcome, Tommy. And we also have with us Miss Sandra Mitchell, RN, and she has been a registered nurse for 28 years. Prior to working at CAIPA MSO, she was the Vice President of Medical Management for a management service organization. As VP, she worked with her team to consistently meet and exceed required key performance indicators while ensuring the efficient delivery of patient-centered care. She was integral for the development of the Transitions of Care program of a large New York City health system. And throughout her career thus far, Sandra has gained experience spanning both provider and payer environments with 25 plus years in the managed care sector. Her primary focus now includes care and utilization management. And she is also a proven transformational leader, showcasing outcome-driven qualities by building synergistic teams and sustaining results for quality care. So clearly we have a very impressive crew here delivering to us today. So very excited to hear from them. I believe Sandra is going to get us kicked off. So welcome.
Thank you, Garrett, and thanks everybody for joining. Good afternoon, all. Who is CAIPA? Now, CAIPA is the Coalition of Asian American IPA. We are headquartered in New York City and serve the greater New York area with over 12,000 physician members and affiliates in over 1,800 medical offices, providing 70 specialties. We serve more than 500,000 patients in the Asian community. We are a vibrant managed care organization focused on quality and efficiency, doing really linguistically and culturally competent care. Sean, next slide. So my role at CAIPA, I joined CAIPA 20 months ago, and it has been literally everything, all at once. I was charged with building a complex case management program, a utilization management program, both aligned with NCQA standards. and really literally starting at zero, because CAIPA had not been doing that kind of case management or utilization management work prior. They really focused on servicing the IPA. I'm responsible for clinical and administrative oversight for the medical management program, and that includes program metrics, performance metrics, patient outcomes, and delegations and compliance. I provide leadership for a care team that has an IDT made up of registered nurse case managers, licensed social workers, and non-clinical coordinators, all of whom focus on care outcomes along the care continuum. Primarily the social workers, not primarily, but they really integrally focus on facilitating linkages to community resources based off our SDOH assessments. The entire team ensures patient and provider engagement, and we strive to enhance provider communication and collaboration around patient care. The nurse case managers really facilitate and emphasize patient education. How did we decide to start our care transitions program? And like I said, it was everything all at once. Care transitions is very near and dear to my heart. Having established a very sustainable care transitions program in a large health system in New York City, it was actually the easiest program to implement because the staff at CAIPA had already been doing some care coordination. And so it was easier to start at that point where staff had a knowledge of what care transitions look like, even if it was a transactional approach. So we developed the program for AACO population to help address patient care needs and to reduce preventable utilization, while at the same time lowering the administrative burdens of the providers. As we mentioned before, we're an IPA with over 1,200 independent providers. And when I say independent, I certainly mean independent. They're all on different EMRs. They sometimes speak a different language. And so really it was a huge lift, but in terms of making sure that providers could see the value in what our team did, this was probably the easiest place to start. So the key objectives of our care transitions program is really to reinforce and facilitate patients' self-management. How do patients manage their care based on the care plan that they had worked out with their providers? So the emphasis was on patient education, patient self-management, developing self-management plans with patients and their caregivers, and thus enabling patients to reach an optimal level of physical, not only physical, but psychosocial wellness, understanding how to facilitate communication with the care team, their case manager, their office staff, their provider, and the other vendors who serve them. And overall, really, if we find that we can prevent care, that patients understand and patients can be their best advocates, then in the long term, we should see a reduction in preventable utilization. So that's essentially the thrust of our care transitions program. And our overall complex case management program focuses on three components. Complex case management focuses on high cost, high utilizing patients, and focus on those patients with modifiable risks. When we looked at our population assessment, we identified that the number one modifiable risk for our patients were patients who had diabetes with some concomitant diagnoses, and we picked CKD and hyperlipidemia because those were the most prevalent amongst our population. So that's the cohort for complex case management. And that services patients who have type 2 diabetes. We also have a diabetes self-management and education support program, a DSMES program that focuses on patients with both type 2 and type 1 diabetes. They are supported by a registered dietitian and a nutritionist support that team with health coaches who help patients to understand managing their self-care around diabetes. And then the Care Transitions program, which I talked a little bit about, but it essentially focuses on patients for the time being who are leaving hospital to home. At a later date, we will roll in patients who are discharged from subacute facilities. So the main thrust is making sure patients understood what got them to the hospital and how do they understand their discharge plans. Are there any care gaps in their follow-up? Do they have the services that they need, and do they understand what the care plan is and what their role is in making sure that that care plan is implemented? So our care transitions assessment focuses really on 13 vital questions. Did the patient understand what got them to the hospital? If it is a chronic disease, do they understand what their red flags are? And I like to talk to the staff about pink flags, because if you are identifying red flags, and it means that you have one foot in the hospital already. So did the patient understand what got them to the hospital? Do they understand what the care was in the hospital? Do they understand their discharge instructions? Do they have any gaps in care coming home from the hospital? Were their medications reconciled? What is the social situation at home? Do they have follow-up care? Was home care ordered? Has home care started? And do they have a follow-up appointment with their physician? What was the workflow at CAIPA before we started this new shift? It was a very transactional approach. A hospital would maybe tell the care managers when a patient was discharged, and the case managers or care coordinators would fax something to the provider to let them know that their patient had been admitted and are now discharged. Half the time we did not get a discharge summary, so we really did not know what the hospital course was. It was very transactional. There was no contact between the care team and the patient, so there was not that that step between the provider, the hospital, and the patient. We didn't get our discharge summary in a timely, or were they consistent, or sometimes they didn't have them. Sometimes the patient was not even ours, or it wasn't our doctor. So, when we changed that paradigm, we began to see a difference in how that worked. And how did we get to CarePort? Next slide, please. Sure. So based on the transactional approach of what the workflow was prior, we looked for something could enhance what we were doing. We understood and we knew, some of us from past alliances, what CarePort brought to the table. We knew their penetration in the New York market with the acute care hospitals, and regionally as well, and post-acute providers, and that would allow us to be able to manage our transitions a little bit more efficiently between acute care, post-acute care, and home. It also allows us to see our patients who are in post-acute facilities and making sure that their discharge plans will be applicable and appropriate for when they go home. The whole idea also of getting the CCD data without the need for individual consent, which is a requirement for most of the HIEs in New York, really created an ease of use for us. The CarePort also has a very robust notification process for workflow management. We get our notifications for admissions and discharges in a timely manner. So we are, instead of being reactive, we're now quite very proactive in telling the doctor, oh, your patient is in the ER, your patient is being admitted in the discharge. So CarePort has really allowed us to streamline that, know where our patients are at a given point in time, and real ease for the end user to use the application with great support from the CarePort team as well. So that has really enhanced our operations at CAIPA. Tommy?
All right, thanks, Sandra. So I want to talk to you a little bit about the CarePort network and our solutions that we have in place. So we have a very robust care coordination network, starting with the acute care hospital and covering the entire post-acute care continuum. We have over 2,500 hospitals and physician practices that are using our various solutions and care coordination tools. We have 130,000 plus post-acute providers that are connected to our CarePort network. We also process around 52 million referrals through our discharge planning products on an annual basis. That touches over 20 million lives, and we're processing over 6 million event notifications a day. So you can see on the heat map here, we have quite a robust network, really spanning the entire country. As Sandra referenced, really giving us a great footprint, especially for her in the New York market and CAIPA overall. Next slide, please. So we have over 500 practices that are managing patients in the CarePort solutions today. That patient population is over 14 million patients that we're managing throughout the outpatient setting. So we have a number of different organizations that utilize our products. We have organizations that are taking on risk from ACOs or private payers, risk-based contracts. We have integrated health delivery systems that are made up of both employed providers as well as non-employed providers and other network providers. We have independent primary care practices. They're smaller independent practices that are utilizing our tools. And then we also have the independent IPAs, such as CAIPA, that are all utilizing the CarePort solutions. Next slide. So we really focus on allowing providers to manage their patients across the care continuum. And we talk about this in really 3 pillars. We want to allow folks visibility into their patients and their patients' movements across the care continuum, that allows understanding of their current utilization and history of utilization, because we do build a historical timeline so you can see the history of where the patients have been, both historically as well as where they are currently. And then providing that intelligence. So we provide a number of risk flags in the solution today around patients that have recently been admitted to an inpatient setting, so that you can have visibility and awareness if that patient shows back up to the ED, that they may be a readmission. The other risk flags are around high utilizers, particularly in the emergency department. Folks that have been to the emergency department 4 or more times in the past 12 months, helping you understand that so you can maybe build out a care plan for those patients, provide better education, and help them understand where they should receive care that isn't in the acute care setting. And then, as well as giving additional insight into post-acute provider performance. So one of our solutions, our CarePort Insight solution, allows you visibility into both the skilled nursing facility setting so that you can see length of stay, as well as rehospitalizations, and then also visibility into the home health setting where you can see start of care. How timely is that start of care? The first day, 2 to 3 days, or beyond, as well as readmissions for the home health agency. So once care is started, are they sending patients back? What percentage of our patients are they sending back in the 30, 60, 90-day time frame? So that's the intelligence piece. And then we want to allow folks to take action on the information and visibility that they've had. So this allows providers to reach out and interact with both the acute and post-acute care management teams to influence that discharge plan. So let's say your practice or provider has a preferred provider network, and you want to help ensure that patients in the various care settings are accessing that preferred or collaborative network. Allowing visibility into knowing where that patient is today can give me the tools to reach out to that post-acute care provider and guide them to the home health agency that my organization really works closely with. So influencing that discharge plan, guiding those patients to your collaborative or preferred provider network, and then being able to do that electronically. One of the things that is a real time suck is picking up the phone and faxing, and then having to go to the fax machine and rifle through a number of papers and find that information. So being able to communicate with those providers electronically, and share documents electronically back and forth through the CarePort tools, really is a time save for the providers that are doing that care coordination and that transitions of care work. Next slide, please. So as I mentioned, we have a variety of tools that have a number of use cases that really span the care continuum. So looking at care coordination, Sandra mentioned real-time alerts. So we can send a real-time alert when the patient shows up to the emergency department, when they are discharged from the acute care setting, when they're admitted to any post-acute care setting, be it SNF, IRF, LTAC, home health. So allowing you that real-time notification of where your patient is across the care continuum. Another really common use case that we have is around ED optimization. So allowing those alerts to be shared can give a care coordinator the ability to know that that patient showed up into the ED, reach out to that ED care management team and let them know that they're there to help, and they can help get that patient to hopefully a lower cost, more appropriate care setting, other than being placed in an observation status or admitted to an inpatient setting, just because the ED may not have confidence that the patient will get the care that they need in the community. Another benefit of the CarePort tools and having that real-time information is around patient engagement. So, there's a variety of programs that various organizations have available, such as CAIPA, for, disease management and those things. And we know that it's a real challenge to get patients to engage with those programs. However, when they're, leaving the hospital or making a transition out of a skilled nursing facility, then, they're vulnerable and they know they need help at that time. So having that visibility into that information can allow you to improve that patient engagement and get to those patients when you need them. We're able to automate referrals, two-way communication between the referrals. We talked a little bit about discharge, or influencing the discharge plan on the last slide. So knowing where that patient is, having the ability to coordinate care with that post-acute care team and get them to the collaborative networks that you have. Transitions of care and transitional care management. So whether you are trying to capture additional revenue with billing transitional care management codes, you have to make that outreach within that 24 to 48-hour time frame post-discharge. And a lot of organizations have visibility into that, maybe through their EMR or through an HIE for the acute care setting. But one of the benefits of CarePort is we have a really robust post-acute network, both SNF, IRF, and LTAC. And so all of those additional levels of care give you additional visibility that sometimes aren't, necessarily integrated in the HIEs, and can allow you to, one, improve transitions of care, but also potentially capture additional revenue around TCM for billing. And then one of our solutions, the CarePort Insight solution, will really help with network management, so that we're providing real-time analytics for post-acute providers in the SNF as well as home health, and can allow you to have that data at your fingertips without manual intervention, to be able to either build out your network if you're getting started and really trying to establish that network, or really dig in to understand the utilization patterns of your current network and look at that. So all of those things will allow you to have, improve performance in your value-based programs and value-based arrangements, really manage those complex care patients, and have that really streamlined provider collaboration so that you can have improved outcomes for your patient, both from a quality perspective as well as financial outcomes for your organization. All right, now I'll turn it back over to Sandra to talk about their specific workflow in our Connect tool.
Thank you, Tommy. I just had a little challenge getting off mute. So this slide actually demonstrates the ease of the CAIPA, the Connect workflow, the CarePort Connect workflow. And you can build different iterations of reports just by clicking exactly what you need. You can see this is our patient encounters tab. If we're looking for patients who are discharged just from an acute facility, or we could actually mix that and look at discharges from everywhere, including home care. We click that, and in a matter of seconds, as if in magic, you will get a generated list. Next slide, Sean. This is what it would look like if you clicked on a patient. For example, if I clicked on Michael Jones, it will give me a history of even where Michael Jones is or was in the hospital for that particular episode of care. So there is granular information that gives you detail on the patient movement across the care departments in the hospital. How do we integrate this in our daily workflow at CAIPA? Because we have a smaller team and we were focusing really on care transitions, and with the resources we had, the best workflow that we came up at the time with, not to really react immediately we get that notification from CarePort, but the next day we would look at all the, let's say today we're looking at all the admissions and discharges from yesterday, notifying providers of who's admitted, and those people who were discharged yesterday, the care team is calling today to get an assessment, to share a care plan with a provider. How do we engage our providers in this process, and how do we engage our patients? Because we're using CMS data, we don't get demographics details. And so when we get a list from CarePort, our first engagement begins with a provider. So not only do we notify the provider that the patient has left the hospital, we also let the provider know that we are going to call this patient. We get the demographics information from the provider. So at that conversation, it's the first piece in the engagement. The provider office in some instances can give us information about the patient that we don't know. So it makes the conversation easier. And in some instances, the providers will reach out to the patient to say, expect a call from CAIPA. So the engagement begins right there. Because when we engage our providers, engage our patients, our results are going to be so much better, because the team it's an endless flow between provider, patient, caregivers, and case management. Next slide, Sean. So from the transactional approach, we actually built streamlined workflows at CAIPA that looked at, when we got that notification, what we did. And at the same time we were building our care transitions program, we were implementing a new documentation system as well. So this actually streamlined the process for staff, walk them through step by step, so that anybody who comes into the organization today would be able to take these workflows and follow them from end to end for the results that we need. So I think not only does having CarePort help us, but building structured and streamlined workflows that were easy for patients to, for staff to understand, made it easier for the program to work as well. And what have we found so far is that we are outreaching 93% of our patients were discharged within 24 to 72 hours. Based on research, we know that once you get beyond that 72 hours, it becomes incrementally harder to reach patients. So we are outreaching 93% of our patients within 24 to 72 hours. That 79% of the eligible discharge were outreach to from facilities, and we've actually increased that 79% to now 83% at the end of December. So we're calling more patients, so we're hoping to reach more patients. We've reached and assessed 60% of the patients that we've outreached to. And so what this has done, it's really helped us to facilitate early intervention for gaps in care for patients who are discharged home from acute care facilities. We get an early opportunity to make sure that medications are reconciled. We ensure that patients, if they don't have an appointment with their primary care physician and they need assistance to make one, we're making those appointments so that they are getting back in to see their patients within 3 to 5 days of that discharge. We're educating patients in the language that they understand, connecting the patients who need psychosocial resources or resources that are not medical through using community-based organizations and organizations primarily that focus on the language and cultural needs. And so we've realized a 2.3 drop in readmission rates. And if there are any actuaries on the line, they can understand what a 1% decrease in readmission, what that translates to in dollars. So not only does this help us to impact the quality of the care that our patients get, we're also reducing burdens for providers, because every phone call that our team makes to a patient is a phone call that the provider office does not have to do. And then when you add the dollars to that, it's where we want healthcare to go. Next slide. Sean. So what's the future of CarePort at CAIPA? At the end of last year, we met with the care team to say, what are some of the things that we're doing now that you think we don't need to do? What are some of the things we're doing that you think we need to stop doing? And what are some of the things that we must do under all circumstances? And the team themselves asked, can we get CarePort for all of our other populations? So that's just giving you a hint of what CarePort has done to their workflow. You know, the ease, the accessibility of reaching patients, the increased collaborations with provider, and they are really impressed with the results, that when we do things in a certain way, then we get certain results. So we are considering to expand our CAIPA roster beyond our AACO populations to maybe second quarter this year, adding 150 more lives to our CarePort population. We're also exploring with CarePort the use of using their insight, which will give us more analytics and quality metrics in a timely way that can help us to really do more focused interventions around discharge planning for patients while they're actually in an acute or post-acute facility. And because CarePort also has a feature where hospitals and subacute hospitals can attach the discharge summary, it makes everything so much more timely. It informs the case manager in a different kind of way before she makes that phone call. So communicating with discharge planners, communicating with providers, having the documents that help us to do that really helps us in terms of establishing credibility with providers and with patients. And also patients are truly impressed when they see that they can be advocates for themselves and that they can really learn how to manage themselves at home. Next slide. Thank you.
Okay, well, it looks like, well, first of all, guys, that was a fantastic presentation. Thank you so much. I got a lot out of that. I'm sure our audience did as well. And yes, we did have some questions that came through. If you have a question that you would like to ask either of our speakers, you can submit it through your attendee module. There's a little place for questions. So go ahead and put it there, and we're going to get to as many of them as we can. We have a bunch that came in, so we're going to do as many of as we can. If we don't get to yours, though, someone will get back to you via email. So either way, you'll get your question answered. So go ahead and ask it. Okay, well, let's just dive in here in no particular order here. First question is, what populations are CAIPA considering adding to their roster, and why?
So CAIPA has VBP arrangements with certain health plans in the New York metro area. Those health plan patients are not currently in our CarePort roster. We're only focused on our AACO populations. So we are considering pulling some of our health plan patients who we have more robust contracts with, who we're also managing the transitions for. So those are the populations that we're considering to add to our roster. And the reasons why: it's the timely notifications that we get. It's our ability to intervene earlier. So just really knowing where a patient is at any given time really helps us along the continuum more. So that's what we're hoping to do in the near future.
Very good. Next question is, did you need to make any staffing changes after implementing CarePort?
We did not really make any staffing changes. We actually used the staff that we had. We just used the staff in a different way. So rather than being very transactional, it's just waiting to get something, we had something now that we could act on. So it was retraining the staff in a more managed care turnaround time frame. So we really just re-engineered our workflows and the focus of the workflows.
Okay. Next question is, have you received any feedback from your staff since the implementation?
We do. We have. They want us to put all of our 500,000 members on CarePort. We're actually at the same time toying with automation. When we get this information from CarePort, can our IT and data analytics team help us to create a case just so that we can impact it from the documentation system so that we're not doing manual work. So the staff has really been integral in wanting this expansion for CarePort.
Yeah, great. Next question that came in, it's kudos on your ACO achieving in excess of 21 million in shared savings.
They looked us up.
They did. In fiscal years 2019 through 2021. What incremental shared savings do you anticipate garnering in 2022 and 2023 through your improved care transition initiatives?
They are actually calculating those numbers now, but the preliminary results were that we're going to better those years, better the 2021 year. So we're excited about that. And what we actually also saw when we looked at our admissions over the 2019 through 22% is that we actually had a drop in admissions. So all of those are very interesting things. We had a drop in admissions, we had a drop in readmissions, and our readmissions numbers were so low that compared to the admission numbers, we were a little bit like, oh my God, is it going to push our readmission rates over the way? But we think that we're going to see also a decrease in readmissions for 2022. So we're excited about that. And we know that one of the reasons for that impact is that it's the patient education. It's the connecting the patient and the provider with a care manager. And there are questions that sometimes a patient won't ask the doctor, but they'll ask the care manager, and the care manager can be the conduit that facilitates that. So it's a number of things, and once we analyze them, we'll see what really are the drivers for change. But we know that CarePort has been a big driver because the timely intervention really makes the most difference in impacting care.
Yeah, great. Next question here is, do you already or plan to collaborate with a local hospital to offer acute care at home services?
We have explored that, and CAIPA has a house calls program. The house calls program was primarily focused on quality outcomes, but we are exploring how can we build a care component in that. Let's say a nurse assesses a patient who requires immediate attention from a clinician, but can't get to the provider's office. How can our house calls team go into that? So we have looked at different models and how we're going to do that. In the New York City area, there are some hospitals that do that acute hospital at home. So it would be not something that CAIPA might do, but it might be something that CAIPA partners with somebody to do. But in the meantime, we're looking at how can our house calls program, which is serviced by physician assistants, NPs, supported by a physician, how can we build more of the home visit component into that?
Great. Next question is, could you describe the infrastructure used to interface care transitions with local community SDOH mitigation resources like Meals on Wheels, et cetera?
Okay, so we have in our complex program a very robust assessment that's divided by domains, and one of those domains is an SDOH domain. When I looked at the SDOH domain that we have in our assessment, we had it was more involved than the validated SDO tools on the market. So we're asking a couple more questions. And we built with the help of the social workers. So we looked at what community-based organizations were you going to for more help, and where were you getting the more prompt help. So we actually built a community resource guide of community-based organizations that we know were going to be timely in how we impact when we refer to them. So we're building that structure and creating those relationships. So we do the assessments through the care transitions assessment. We do a depression screen as well, and then we connect them to a social worker who can connect them to a behavioral health provider, or if it's other resources for Meals on Wheels, then we do those connections as well, those linkages.
Great. Next question here is, how are post-acute providers integrated into the system? And do they have to log in, or is there some kind of connection with their existing systems?
I can take that one. Yeah, so we do direct ADT connections with the post-acute care providers. So when we bring on a new organization, we have a team that does outreach to those post-acute care organizations that are within your collaborative care network or in your market or region. And we'll do that outreach, and then we'll get a direct connection from their EMR. So they'll provide the ADT connection into CarePort, and then that way it doesn't require any manual intervention. So they don't have to go in and enter admission dates or discharge dates or those sort of things. And that's how we're able to drive those real-time notifications of admission and discharge and transfer, potentially back to the acute care facility or that sort of thing. So that's the way that we get data in. And then all of the post-acute care providers, we don't charge them anything to contribute data, and through contributing data, then they get a contributor view. So they're able to see the same thing that you see. So I don't know if you all noticed in the presentation, but on the slide with the kind of patient summary, there was a flag on there that indicated that it was a CAIPA patient. And so that's called a roster tag or attribution. And so the post-acutes can also see that, as well as care coordinator information if you're uploading that and that sort of thing. So they can know that that is a patient, that patient is part of the CAIPA network. And so that then they can coordinate care. If they log into their contributor view, they're able to see that And then from the analytics perspective, they can also see the same analytics calculation that the subscriber or the organization that has purchased CarePort can see. So that allows that collaboration on, rehospitalization rates and length of stay and that sort of thing specific to the patients that they share.
And Tommy, maybe you could actually expand on the last question I answered about how a referral could be made from CarePort to a community-based organization as well, because that's the piece that we don't currently use.
Sure. We do have, as part of our care management solution, we have a CM neighborhood referral platform that does allow for sending electronic referrals to SDOH type organizations. So, be it food, housing, those sort of things. So we do have the ability to do that coordination, and those post or those SDOH organizations are able to receive those referrals electronically through that application as well.
Thanks, Tommy.
Thank you.
Great. Next question here is, do you stratify your patients, or do you contact all patients with inpatient utilization?
At CAIPA, we currently do. We're not stratifying our patients. We call all patients who are discharged from acute care facilities. As we add populations, though, there will be a need for risk stratification, and we're exploring LACE to do that.
Just to elaborate on that within the system, so I mentioned those tags in the roster. So if you are stratifying your patients, and let's say you have, high risk, moderate risk, low risk, you are able to add those tags to the roster submission that you would have, and then you can filter your patients down to those specific risk levels, as well as receive alerts based on those specific attributions and risk levels. So if you're providing that information to CarePort, then we can target those alerts. If you wanted just alerts on your high risk patients or alerts on your moderate risk patients, we're able to target those alerts through those attribution tags.
Okay. Next question here is CarePort another layer for Allscripts platform?
So CarePort was acquired by Allscripts initially back in 2017, 2018. And Allscripts care management solution was pushed under the CarePort umbrella. So the old folks may refer to the Allscripts solution as Allscripts or as ESON, but it is now all CarePort. So CarePort Care Management is what folks will often refer to as the Allscripts platform or ESON platform. And then in 2020, we were acquired by WellSky. So now you'll notice in our signatures and things, CarePort powered by WellSky. So we're part of the WellSky family of solutions, and WellSky is a healthcare technology provider. And so the WellSky has a variety of solutions outside of just the CarePort products.
Great. Yeah, that's a good explanation. Next question here is, do you have any statistics relative to how many case managers it takes to make the transition of care calls per X number of discharges, like within 24, 72 hours?
That has been the age-old question in case management. What is a reasonable caseload? And we really don't have the answer to that yet. We're still working on the algorithms, and once you have the risk scoring, it becomes easier because then you can actually assign based on skill level. But no, we don't have. I can't give you a statistic right now.
It's a lot of moving parts and
It is a lot of
things to
moving
track down.
parts, yes.
Yeah.
And so we tend to look at it on a daily basis and say what needs to get done and how best is it going to get done and who is the best person to get it done. So but that's all in our future planning too, for complex case management and caseloads and case mix and what's going to be reasonable for a case manager.
Yeah, it's an ongoing search. I'm sure. Okay, next question is, Sandra mentioned connecting patients with community resources. How was that SDOH process constructed?
How was that process
I
constructed?
guess maybe
So
they're asking how did you approach putting that together?
together?
Yeah.
Okay. Um, in the fact that most of our patient population are either Cantonese or Mandarin speaking. So once you assess a need, you look at the community-based organization that's going to support that patient best. Where is the patient going to feel more comfortable? So that's an ongoing process. And over time, people had built a repository of organizations that they worked well with. And we tend to, we're creatures of habit. We go back to where we get the results. So in the absence of having any official structure, we work with what works. And a piece of our long-term plan is to work with those community organizations to see how they can get into the New York State community-based organizations network. That's something that's coming down to the pike. So we're working with a consulting group to see how we can help those alliances. It's everything all at once.
That's right. It certainly is. Okay, next question here is, are you or are there any plans to do any RPM or remote patient monitoring with your patients?
Yes, we are. And our House Calls program just received a 1.2 million grant from New York State.
Oh, wow.
And what we had designed that program around was looking at how can we give equitable and holistic care to Medicaid patients in the Asian population, and how can we leverage remote patient monitoring to do that. So we just got that grant maybe about 2 weeks ago, but the construct of the grant was for patients who may not be able to get out to their provider. How can we implement some programs for remote patient monitoring? So yes, that's on tap.
Okay. Next question here is, are Medicaid patients covered? And if so, how does your staff impact social determinants of health with them?
Are Medicaid patients covered for what? I'm
The
not
question
sure.
doesn't specify. It just says, and maybe that might be something we have to get back to you via email to
Okay.
answer your question more specifically. So, okay, next question here is, CarePort's process starts with patient discharge, and best practice is to start care transition before discharge. What are CarePort's plans to achieve this?
We actually have information on admission, so that is one thing. We can send alerts as patients show up to the ED, and then you can see visually in the platform as they transfer to an inpatient or even an observation setting. So having that visibility into that does allow your community-based care managers to do that outreach to the acute care setting, to have that conversation with the acute care manager, maybe guide them to your collaborative network if it differs from the acute care collaborative network, so that they have that understanding that as you're managing that patient in the community, you want them to go where, as Sandra mentioned, you've seen the results. So you want them to get to your provider. So having that visibility through the CarePort Connect tool does allow that outreach during the acute care episode of care.
Very good. Well, unfortunately, that is all the time we have for today. We were right up on the hour. It was quick. But I wanted to thank again our speakers, our presenters today. This was a very informative session. And as we close out, I wanted to encourage you all to visit vbcexhibithall.com, and you can actually check out the CarePort exhibit booth. They have a virtual exhibit booth there where you can interact with their team, look at a lot of different resources that they have. There's a lot there that you could spend some time seeing what they're doing in the value-based care world. So that is at vbcexhibithall.com. Also, that is vbcexhibithall.com is where you'll be able to find the webinar recording in our library there. And there is an archive where you can look and see all the webinars we've ever done, but this one will definitely be in there for you. But that said, I am also planning to, if you missed it at the beginning, I am planning to send a link out to everyone who registered for today's session, and you will receive a link to the recording where you can also download the slides from today's session. And then finally, if you would like to reach out to our speakers or to the CarePort team, feel free to do so here. That email CarePort at careporthealth.com will get you there. Or you feel free to reach out to me as well. I'm happy to connect you in any way that I can. But I wanted to, again, say a big thank you to our speakers and to you for joining us today. I know there's a lot vying for your attention, and we're glad you spent the afternoon with us. So thank you so much for coming. Have a wonderful rest of your day. Bye-bye.